Afternoon and welcome to the webinar, the CAQH Index, How Healthcare Providers Can Participate. My name is Karen Waller. I'm the Director of Communications and Marketing at CAQH, and I'll be your moderator for today's webinar. Before today's session starts, I'd like to review a little technical information. Your phones will be muted throughout today's presentation, and at any time during the session, however, you may ask a question through the web. Just submit your questions by entering them into the questions panel on the right-hand side of the GoToWebinar desktop. And our panelists will address questions at the end of the session. You'll also be able to access a PDF version and a recorded copy of today's presentation by going to our website, caqh.org, and clicking on the CAQH Index tab. We'll also send all webinar registrants a link following the webinar to those materials. Please note that the recorded session may not be loaded until tomorrow. Now, I would like to introduce our speakers. We have Gwen Lowe's at CAQH. Jeff Lemieux, who is a research consultant at CAQH and has been a lead researcher and author on the upcoming 2015 Index webinar, as well as past Index reports. Ken Copeland from NORC. Ken is Senior Vice President of Statistics and Methodology. We also have Bruce Trickle, Albany Internal Medicine. Bruce is the administrator at Albany, the lead administrator with the Accountable Care Coalition of South Georgia, as well as president of the Albany Medical Managers Group. Unfortunately, Adam Gottmik from Emory Clinic is unable to join us today because of a staff emergency. However, he did prepare slides for today's presentation, and we will be reviewing those slides with you at a high level. Now I'd like to turn it over to Gwen.
Great. Good afternoon, everyone. So we're going to try to give you an overview of CAQH and the index. And some of you may be very, very familiar with both areas, so bear with us. Then Jeff is going to give some detailed information about the index, some of the 2014 findings, and then we'll go in and Ken will talk about healthcare provider participation for this year's index, the what, when, and how you would work with NORC, because they are, as Karen highlighted, consultant for the provider participation, and they'll be working with Milliman on the analysis. Some of you worked with Milliman last year. And then we are going to hear from our provider participants. Specifically, Bruce will talk about Albany, and then we will highlight, per Adam's request, some of Emory's experiences. And as you can see, two very different organizations, a practice group and then a large health system, both participated, and we want to send the message that all types of providers are needed for the index. So no matter what type of provider you are, we really would like you to participate or let your colleagues know. And Adam is available for questions for those of you that do want to talk offline, and I'm sure Bruce would be, but you'll have a chance to have a Q&A with him today. Overview of CAQH. For those of you not familiar with CAQH, we are a nonprofit, been around for about 15 years. We are focused on the business of healthcare and streamlining that. Work with collaboration between healthcare plans and providers, and really working to deliver value to the providers, the patients, and the health plans. We do that through a number of different initiatives that are all organized a little bit differently to make the effort that specific initiative is around. One of them is COV Smart. That's around coordination of benefits. And you can go on to the CAQH website and learn more about COV Smart. It is a new initiative, and it's rolled out throughout the U.S., and it's helping identify which patients have dual coverage potentially, and allowing the health plans and the providers to quickly identify which patients do have dual coverage to help you ease that administrative burden. And we have quite a lot of participating health plans. Over 120 million lives are covered by that, and so do take a look. Then CAQH ProView, which is focused on provider demographic data that's used for health plan directories, the credentialing process. And there's over 1.3 million providers in that. And again, go to our website. We've just moved to a new platform and learn about that process. Enroll Hub, which is for many of you that are on the line, you're familiar with the various different HIPAA transactions. So instead of having to enroll for EFT and ERA with each health plan, you can go in for free, and all these COV Smart, ProView, and Enroll Hub are free for the providers. You can enroll once with Enroll Hub, and it will go out to multiple health plans, so do take a look at that as well. Another initiative is CAQH Core. That is focused on the development and implementation of mandated operating rules. And I think many of you are familiar with the concept of operating rules, but they do cover many of the transactions that are in the index. And then the last initiative, the index, which we're going to go over in detail today. With the next slide, it just gives you a very high-level overview of the index. And the CAQH Index had been in the marketplace for several years. And we'll go to the next slide in a second. The index was created back before the healthcare reform bill, and was actually initially managed by MDON, and the ownership came over to CAQH several years ago, and we're extremely excited to have the index under the CAQH umbrella because it really does complement quite a lot of what CAQH is working to accomplish. With the index overall, we are focused on tracking the progress of the transition from manual to electronic administrative transactions. It is an annual report that does occur. So that annual report is a combination of health plan data and provider data. And I was looking at both the adoption of each of the mandated HIPAA transactions as well as the cost of those transactions from the perspective of the health plan as well as from the perspective of the provider, and then extrapolating that and presenting a cost savings for the industry at large. And you'll see within the report, and Jeff is going to highlight this a little bit, that the index looks at fully electronic, so those are fully standardized, partially electronic, so portals or interactive voice, and that may be, then there's manual, and that partially electronic, it may be viewed by the health plans as more standardized and completely non-manual, but for the providers, there really is some manual aspects when it's portal or voice. So we look at all those aspects within the index to come up with the potential cost savings for the industry. There is a council that guides the index, and they're experts in claim-related transaction. It's a mix of healthcare facilities, provider practices, health plans, and other entities like CMS. And with that, I'm going to hand it over to Jeff, and Jeff is going to walk through some of the findings from last year and the process. Thank you.
Thanks, Gwen. So this year's index report came out in March. It was from data from 2013, and what we're doing now is collecting data in 2015. We call it the 2015 index. It will contain data for the full year of 2014. And so what does it mean to participate? So what we do with the index is we collect a great deal of information from health plans, and we also collect information from a group of healthcare providers that have volunteered to participate. And the way this works is you contact us, and our contractors at National Opinion Research, University of Chicago, will talk to you and figure out how to contribute data. It's a fairly straightforward process that Ken's going to highlight in a minute. And what you get from that, in addition to feeling great about participating in the process that gives data for the whole industry to understand how we're making progress on switching from manual to electronic transactions, is you get a benchmarking report back to see how your industry compares. with the overall totals. And the reason we're trying to get more provider participants is so that we can provide more and more detailed benchmarks by hospital, standalone hospital, by health system, by healthcare provider, medical group, large and small. And as we get more participants from the provider side, we're hoping to get better accuracy in our measures, better benchmarks, broader benchmarks, and improved estimates of overall cost savings. And I think that we're really getting a lot of momentum here. We've increased the size of our survey in the last 2 years, and we're really excited about that. If you go to the next slide, I'll show some of the data. The statistics that we gathered last year and the year before are information on claim submission processes, eligibility and benefit verification processes, prior authorization requests, claim status inquiries, claim payment, and then remittance advice, or the explanation of benefits, explanation of payments that goes along with a bill payment. We also started looking at some additional transactions, such as the attachments that medical groups and hospitals would have to send attached to a bill or in conjunction with the bill in order to receive payment, and how much does that cost, and how often is that done. And so here are the top line results. This is important. Even with just these 6 transactions that we studied, claim submission, eligibility and benefit, prior auth, claim status, claim payment, and remittance advice, we computed that if the industry moved completely to automated electronic transactions, we could save $8 billion. Our estimates indicate that healthcare providers would save most of that money. For reasons that Gwen alluded to a few seconds ago, in that if we can move to fully standardized transactions, that even the things that are done on a health plan website or through an interactive voice or other sort of semi-automated system, if it were fully automated through your practice management and administrative IT systems, then that would create additional savings for healthcare providers. So on the next slide, this is the slide that usually stops the show when I'm making presentations. This is the estimate. And these are our best estimates for healthcare providers and for the industry as a whole. And as you can see, if you look at, for example, prior authorization, we estimate that that costs about $14 to handle the processing on healthcare provider side, and an additional $4 or so for the health plans, to make a total industry cost of about $18. On the other hand, if you switch to electronic transactions, the cost is still formidable, but much, much less. So these are the sorts of estimates that drive our cost savings of how we can save $8 billion in the industry if we keep moving toward electronic transactions. And here's why that is possible, the savings. We estimate that for healthcare providers, claim submission is already mostly standardized and electronic, about 92% electronic, 8% manual. However, in most of the other categories that we studied, we're finding very large shares of manual transactions by phone, mail, and so on. So that's where the savings come from, is trying to convert those manual transactions towards standardized electronic transactions. And the last thing I wanted to mention to you as you're considering participation is that we've put on our website a savings calculator so that either healthcare plans or provider organizations can estimate their data and see how much savings would accrue if they were to move from where they are now to 50% electronic, 25%, 10%, to try and get an idea of the savings that would accrue. And at this point, I will turn it over to Ken from NORC to explain how we're going to be collecting data from healthcare providers in this year's index. Ken?
Thank you, Jeff. NORC is a not-for-profit social science research organization. On the next slide, just provide an overview of who we are. We have over 70 years experience in survey design and operations, data collection, dissemination, analytics. And much of our experience has been in collecting confidential healthcare information, such large surveys as National Immunization Survey, National Survey of Children's Health, Medicare Current Beneficiary survey and a number of surveys involving collection of data from physicians and other healthcare entities. CAQH has engaged NORC to, on the next slide, carry out the provider engagement to contact and obtain agreement to participate, providers, collection of the data and analysis of the provider component. And our role includes working with CAQH to implement improvements to the collection instruments. We're, as we'll talk about a little later, setting up the survey as a web-based tool for those of you who have experienced this in the past. As I said, provider engagement, participation, providing access to participating providers for support in the data submission process, and then finally working with CAQH and the Council on Analysis. On the next slide, we provide an overview of the process for 2015. So the first step is participant recruitment, which runs from now with this webinar through mid-June. So NORC will be making outreach to the provider community through this month. Then in June, the rest of June and July, we'll be making follow-up contacts where necessary by email and phone, looking to obtain provider agreement to participate in the index process. And the objective is for those that do agree to participate to identify a point of contact, a start date, and collection mode. Collection mode being web survey or Excel. And the start date, in order to meet the completion of data submission and analysis and report generation, will need to be no later than August 14th. Data submission will be carried out from early July through mid-September. It will begin with a training webinar that participants will receive an invitation to. Upon the agreed upon start date, the point of contact will receive the web link or the Excel file if that was the preferred method. And then as each provider can have a different start date, there will be rolling submissions looking to have each provider complete the survey within 4 weeks of the chosen start date. And throughout this process, NORC will be providing ongoing support, touching base with providers, and being available to answer questions as needed. Then following completion of data submission in mid-September, then NORC, CAQH, and the Council will analyze the data, and by late this year or early in 2016, the index report will become available, and subsequently providers will receive the benchmark, their individual benchmark reports that Jeff referenced. So let's look at each of these segments. First, getting started, this June 10th, this webinar provides an introduction. As Gwen had mentioned, a recording and the materials will be available online, and also reference for those who were not able to participate in this webinar. Then we, NORC, will begin contacting providers by phone or email, asking for their interest in participation. And as needed, we'll be recontacting through email and phone follow-up. And what we're looking to do is to answer any questions providers may have about participation, the benefits, and Bruce will talk a little bit about that, and obtain agreement to participate. For those of you that agree to participate, you'll be asked to identify a point of contact within your organization, a start date for data submission, And based on our prior experience, we recommend that providers treat this as a project that spans up to 4 weeks with a few hours per week as needed. And then the mode of data submission, whether web or Excel. On the next slide, we then talk about what's needed in starting collection. As I said, the point of contact, this should be someone who would be able to complete the survey or to be the coordinator within your organization to reach out to staff to complete the survey. The start date would be any time from early July to no later than August 14th, so that there's time for your organization to resolve any questions you may have with your data. And in picking the start date, you'll be picking the 4 weeks to gather the data and complete the survey. And so there, you would complete the survey, we'll review, and NORC would reach back out to your organization if there are any questions. So on the next slide, then let's talk about what information you're asked to report should you participate. We'll talk in more details about these, but it's 3 areas of information. First, looking for data on staff effort associated with transactions. So the number of staff and the percentage of time that is spent. Second would be salary data for staff that are working on these transactions to be obtained from your annual budget or monthly payroll. And then finally, information on the volume of transactions by type and whether it's electronic or manual. You'll also be asked to indicate the reference period, which is to be the most recently completed year, whether fiscal or calendar, and likely that would be 2014. As we go through the detail information, said you may have some but not all of this information, but you could still participate even if you don't have all of the information that's needed. And again, an analyst from our organization would work with individual providers to determine the best approach to report the data. Next, let's look at the information on staff effort. So here it's information regarding the time your staff spends on specific transaction. So you see here 2 of the questions that are involved: how many billing staff are involved in conducting each of the following? These get back to the types of transactions that Jeff referenced. Then second, how many front office staff are involved in conducting eligibility verification, pre-certification, prior auth, and referral certification and approval. And then the other piece of staff effort information on the next slide would then be related to the percentage of time on average that those staff are spending on then each of those types of transactions, and looking at both manual and electronic. So that's what's asked for in terms of staff effort. The next piece of information is salary data on the next slide. And here, the point of contact would need to access either your annual budget information or monthly payroll to provide the salaries of those spending time on transactions. So again, going back to average annual salary of billing staff who are working on those different types of transactions, average annual salary of front office staff, and for hospitals would also be asking what is the average annual salary of case management and utilization staff. And the final piece of information that we ask for is volume data. So by transaction type, asks for an estimate of the volume of transactions that occur within your practice per month, and then of the staff involved in the activities, the allocation or the distribution of transaction processing, whether it's manual or electronic. So with all of those data, then we are able to analyze the data and develop the statistics, the measures that Jeff discussed earlier to develop the index report. So just some additional pieces of information on the next slide. I just talked about the information that we're collecting. What does the tool look like? We've been working with CAQH to continually improve the process. Some of you may have participated before with the Excel spreadsheet. The survey has become web-based. What key capabilities that we've worked on developing is a user-friendly web interface. Each question has built-in explanations and support. It enables multiple staff to easily enter data, and there are built-in checks for data quality. However, if your practice is unable or you prefer not to use the web survey, an Excel version of the data collection tool would be emailed to your point of contact. During the data submission process, there's a variety of support and guidance. First of all, as I indicated, the web instrument includes guidance on what transaction costs to include, suggested methods for calculating the various items. This information will also be available within the Excel spreadsheet. As I mentioned, we will host a training webinar in July. We will announce this 2 to 3 weeks ahead. And again, if you can't attend, these materials will be available online, just like this overview webinar. And finally, NORC staff will be contacting at touch points through the process and also available in response to questions that you may have. And next. One thing we do want to reinforce is the confidentiality of the data that you provide. Each individual organization's submissions and data is kept confidential. The index report contains only aggregated data. No individual organization data is in the index report, nor possible to be determined through information in the report. One of Gwen and Jeff have talked about benefits for participation. Obviously, one is the altruistic, that this information is critical to the industry, and provider participation is essential to provide quality information. And in addition, there's the customized benchmark report that's provided to each contributor. I'll provide a brief overview of what is provided, and Bruce will talk some about how his practice makes use of this information. So on the next slide, we see one table from the benchmark report. Here you see the average unit cost, as Jeff had referenced earlier from the report, and then your individual unit cost would be provided as well, along with the difference, so that you're able to see how your practice compares against the national average in terms of the unit cost. And a second table that's provided in the benchmark report on the next slide shows the comparison of the distribution of transaction submission or transaction type by modality, manual versus electronic, again, the national level average, and your experience provided as a contrast. Last thing that I want to talk about, especially for those of you who have participated in the past, as we said, CAQH looks to continually improve the process and the index data. To date, the tool is focused on labor costs associated with transactions. We're also interested in broadening the scope through questions that focus on vendor costs. With your vendor or vendors. And then finally, you'll be asked to report an estimated cost for each vendor type that you have indicated. And here we understand that costs differ by provider size and vendor approach. And so the data collection tool will be customized to the size of your practice as you would have reported at the beginning of the data collection tool. And again, we understand also the sensitivities of providing exact cost information, so we will only be asking for ranges. That concludes my review of the data, the provider recruitment and collection process, and I'll turn it over to Bruce Trickle now.
Great. And Bruce, I know Adam was going to go first. We are going to, just given we had his slides there, we're going to just kind of run through those. And again, for those of you that are on the phone, if you are a health system and you want to talk to Adam afterwards, he's made himself available. He's very disappointed not to be on today's call. So I'm just going to quickly run through these slides. Some of you may be really familiar with Emory. It's a very large organization, and they work with CAQH in a range of ways, including the index. And on the next slide, you'll see what Adam did is to provide an overview of the experience Emory had with the index last year and the steps, because they are so big, to approach the index. So you'll see for each of these boxes, he provided a little bit more detail, and I'm just going to highlight those. But getting the team together, educating them on a process to collect the data that's needed, building the report to collect the data, and then validating that. And then you'll see, most importantly, after they did that, they were then able to, as an organization, partner with some of their payers and other trading partners to improve processes. So getting the team together, and obviously it would depend on every single entity is a little bit different. So they had an operations analyst, managers, and then the senior leadership to sign off, which I think is extremely important, that every entity gets someone to get the buy-in that they're going to take the time to do this. Then on the next slide, educating the team, so they got together and just made sure that everyone had the same interpretation, and the both of the data needed to be collected and how they were going to provide it into the spreadsheet. Then building the reports. So they have they actually have, Adam to go into this more detail, they use their billing systems and their vendor systems to populate the fields, and then they were able to quickly tell what was actually manual, what was electronic, and then able to send draft reports that fed into the data. With validating, getting that report out to all the people involved before they sent it off to us. And I know they did work last year, Milliman, who is still working with us, and they're actually on today's call, Milliman helped them with the analysis. So this year we have NORC, which is doing some work with each of the, if you participate, NORC will work with you, and then Milliman will also work with us on the final analysis. So you will have assistance, and Emory found that really valuable last year. And then finally, once they did all this and they had their benchmark report and they were really able to look at how they were doing, taking some of that data and then working with payers to do meet certain deadlines or meet certain goals based upon the findings. So they were able to drill down to the next level to say how can we use the data to improve our processes. And they've done a lot of interesting things in this area as a result of the data. So hopefully, again, if you are interested, Adam said it's a very doable process, and it's allowed Emory to then shed light on other things. And it's free too, and the benchmark report is free. So Bruce, I'm going to hand it over to you and give us your overview as we move through to the next section.
Sure. Well, if you can go to the next slide, that would work. Albany Internal Medicine is a physician-owned, multi-specialty primary care group. We're all ambulatory. We're one facility at one site, 13 providers, and about 74 staff. We organized a independent physician group Medicare Shared Savings Program, ACO, started that in 2013, so we're into year 3 with that, and also pursued NCQA, Patient-Centered Medical Home Level 3 recognition, which we attained in 2014. As a practice, I've always tried to encourage the group to participate with key surveys nationally, specifically with MGMA and CAQH, because the data that's provided as a result of those participating in those surveys help you with benchmarking how you're doing either regionally, nationally, and it also helps you with leverage at times depending on your discussions with carriers. Now we're a smaller group, so the process was primarily managed by me as the administrator, and I solicited information from staff. In a larger organization, you probably would have assigned several staff members to do certain pieces of the survey. But what I found is that really in reality it only took a couple hours a day for about a week to put together the information needed to submit the survey, and then I spent 3 or 4 hours validating what I had collected, and also taking a closer look at some of my processes internally. I think the thing I benefited most from, and our group benefited most from, and it's probably maybe a side benefit, we really learned about how we manage the business office processes for the most part, the claims, collections, and the entire revenue cycle management, and eligibility checking, et cetera. I learned a lot just by going through the survey about how we're doing business, a lot more than I really realized I was in touch with or not in touch with in this case. And it allowed us to, after we got the final results and worked through some things, to refine some of our own internal processes and improve our return on investment on our staff. I actually took a staff of 5 and was able to reduce it to 4 and reassign the 5th person to other duties to help with the organizational business needs. And that in itself helped tremendously because it saved me from having to hire an additional person for that particular position. And I think we're more efficient as a result. Of course, this took several months to work through, but again, what we learned in gathering or collecting the data allowed us to better understand our own processes in a lot more detail. I found the process helpful, and you know, Milliman, who provided a lot of feedback and answered our questions, was very receptive and always, you know, on point, but didn't also, you know, interfere with the, you know, the process. So I definitely will participate again, and encourage small or large groups to participate. And I guess we're down to asking for questions.
Yes, we are. Let me remind our participants today that you may enter your question by typing it into the space on the right-hand side of the GoToWebinar desktop. And so we have a first question. Do I have to complete the entire survey? Jeff, would you like to take that question?
Sure. The answer is no. We're able to accept partial data in this process. We understand that there may be some cases where you could have information on 4 or 5 of the transactions, but not a couple of the others. It happened last year where some of the participants had data on the 6 main transactions, but didn't yet have data on their attachments. So the process is ongoing. We'll work with you to get the data that we can from what you have for this year, and partial response is useful.
Thank you, Jeff. A question for Ken at NORC. Is it possible to have multiple staff filling out the survey?
Yes. Well, both modes are. So with the web survey, it will be possible for the point of contact to have designate someone to fill in information for particular items. Obviously, we're looking for the point of contact to coordinate that collection effort, but it's not solely up to that point of contact to enter all the information.
Yeah, I'll use it as an example, like collecting salary data. I carved out of the workbook a piece and sent it to my bookkeeper to, you know, basically fill it out, send it back, and I just cut and paste. It did that with a number of the different sections because, you know, some people within the organization could answer it easily. So.
Thank you. The next, we have another question for Bruce. Now that you're a veteran participant, what will you do differently this year?
I probably involve more of my frontline staff in the collection process, because I think what I learned about our, you know, internal organization and how we operate, I think they need to learn, you know, see it from the same vantage point and learn also, because it will help them in making suggestions and or contributing to improvements within the business process within the group, and that's what I intend to do with this year.
Thank you. Another question for Ken at NORC. We're not as far along as our peers in the use of some electronic transactions. Do you still want my data? Would it be useful for the index?
Certainly. What we're attempting to do through the index is to profile the entire population of providers. So the purpose is not to profile what's happening in those that have fully implemented this, but to provide an overall view of the industry. And so therefore it is very important that all types of providers participate in the index.
Thank you. Another question for Ken. I'm interested in having our organization participate, but I don't know how to approach such a large project. How specifically will NORC help me and my organization participate?
Well, we will be available. You can reach out to us when you sign up or when you indicate that you're interested in participating, and ask for help in walking through the process. So one, we can walk you through the instrument, through the web survey to show you and explain the information that we're asking for, and also look to address your particular situations. Bruce alluded to that obviously each provider may have a slightly different situation, and so by reaching out to us, we can help you to understand how your particular situation gets handled in the tool. We will also be touching base with you periodically through your 4-week period, just to make sure that there are no questions or if there's anything that we can do to help you in the process.
Just to mention, I didn't find the questions that daunting to not be able to answer them. You know, whether it's, you know, something we had specific data on that was electronic, or if it's a manual process and you have to kind of estimate the time investment based on staff feedback. But you know, if you take a look at the survey questions, they aren't that daunting. So.
And actually, Bruce, that leads into another question that we have. Were your organization's systems already set up to capture the necessary data for the index, or did you have to create new systems?
Well, I'd say probably in 40% of the cases of the questions, it was readily available. Already had reports or, you know, metrics established to capture the data. The other 60%, you know, really, you know, I had to dig a little bit, but, you know, for this year, you know, I've got things in place based on last year's survey to more easily capture that through a, you know, a more electronic means. You know, I guess the greatest amount of my time on the non-electronic issues were in interviewing staff, and you know, so I don't know if that answers the question, but.
Again, another follow-up question: who did you have to convince in your organization to support participation, and how did you do so?
Well, I'm fortunate in that my organization is made up of some very forward-thinking physicians who have very good business minds, which is kind of doesn't go together sometimes. And hopefully there's no physicians on the line. But you know, they just trust in that, you know, my time spent is, you know, with a value, you know, added project, and you know, it's a good return on investment. And this definitely was, you know, for us, because even going through the NCQA process, the restructuring our business office, and our ACO, and some of the business relationships that we had to establish for it, this helped me considerably.
Okay, thank you. A question for Ken at NORC. What's the best way to understand and get comfortable with the data, standards, and submission guide that you refer to in the presentation?
Well, as I indicated, if you open up the web survey, each item has links that provide descriptions for what we're looking for. If there are questions around what should be included, should not, how to obtain the data that are requested, you can use that link. And again, you can also reach out and contact NORC and discuss those as well.
And even the Excel spreadsheet has the definitions for each of the fields and the questions, and it was pretty self-explanatory.
A follow-up question for Ken: will NORC walk through the process, the questions with us each sheet with us if we want them to, or if we want you to?
Certainly, you know, and that's not a problem. And you know, we're available for whatever level of support you might need. You know, Bruce mentioned that he felt that it was fairly self-explanatory. In other cases, providers may wish, you know, for help so that it shortens their time that they need to spend as well. And we're available to provide whatever level of support you feel is appropriate.
Well, with that, I think we have addressed all of the questions from participants today. Let me just finish up by giving all the attendees some additional information. We do have more information available about the index and participating on our website, CAQH.org. Again, go to the tab on CAQH Index, and you'll find information there. You'll also see a copy of the Fall 2014 Index report that you can download at no cost, and also the savings calculator that you may look at and enter your own data into. If you are interested in participating or have additional questions, please contact Gina Veazey, who is with Communications and Explorations. She will forward your questions and information to the right person on the team. Her email is G and her last name Veazey, V-E-A-Z-E-Y, at CAQH.org. With that, we conclude our webinar today, and we thank you for your participation. Good afternoon.